Patel. I'm a breast imaging radiologist at Ohio State University, and I'm going to be showing some cases and talking about what we do as breast radiologists. So just to give you guys some background, to become a breast radiologist, you have to complete, after medical school, you have to complete 5 years of diagnostic radiology residency. And then at the end of radiology residency, you can choose to specialize if that's what you want to do. And I chose to specialize in breast imaging, and that is a 1-year fellowship after radiology. And breast radiologists, we interpret cases and images, but we also perform breast biopsies and procedures. An important part of a breast radiologist role is also to educate ordering physicians about the different tests we have available and the type of procedures we can do for patients, and also to advocate for patients and make sure that they understand the screening options that they have. Okay, and at any time, if you guys want to stop me and ask questions, let me see if I can pull the chat. Do you guys normally just unmute and ask questions, or do you prefer the chat?
Students can use the chat if they want.
Let me see if I want to be able to see the chat while I am sharing the screen. Let me see if I can pull that up. There we go. All right. Okay. I'm going to put this in the corner. Sorry. Okay. So, all right. So what do breast radiologists do? I think I told you a little bit that we interpret images, and one of the main imaging studies that we do interpret is a screening mammogram. So what is a screening mammogram? A screening mammogram uses x-rays to image the breast in order to identify an abnormality that could be a breast cancer. And this is used to evaluate asymptomatic people. So if you guys might already know this, but a screening test should be an inexpensive test that is really easy to administer. And you want to be able to detect disease before it's at a critical point, before it's spread to the rest of the body, or before it's in a late stage and you have less treatment options. So, so a screening mammogram is used to evaluate asymptomatic women. And most often the radiologist doesn't see the images until the patient has left the department. So the technologist will take those images. And then as a breast radiologist, we will read them maybe later on in the day. We normally read about 15 to 20 at a time so that we can get through a lot of patients, okay? So what a screening mammogram is 4 views of each, 2 views of each breast, so 4 views total. The technologist will take a cranial caudal view, so cranial is head, caudal is feet, cranial caudal view, and a medial lateral oblique view of each breast. And as a radiologist, this is what it'll look like on our monitor. This is how we actually just display it with the head is at the top for the MLO and the feet is at the bottom, and the nipples are pointing outward. And this is, we place the right on the side and the left on the side. And this is the cranial caudal view where the axilla is on the top and the medial portion of the breast is on the bottom. And again, the nipples are pointing outward. So this is what an actual mammogram looks like. This is the right CC, left CC, right MLO, left MLO. 2 views of each breast. And we use the nipple to demarcate the outer portion of the breast and the inner portion of the breast. And same for the MLO. And if you can see on the MLO, this is actually the pec muscle, the pectoralis muscle here. So we can see lymph nodes under your armpit, and we can see a muscle right here. And we use the nipple again to say is something in the upper portion of the breast or the lower portion of the breast on each side, okay? All right, so what do we look for? We look for masses, we look for microcalcifications, these little white dots, and we look for tissue distortion. So a mass is a 3D structure demonstrating convex outward borders on 2 views. And we comment on everything if we see something abnormal. We comment on size, shape, density, and location of the mass, but margins are some of the most important features. And these are actually the words that breast radiologists use. And these specific words that we use in our reports sort of indicate how worried we are about something. So if you are shadowing in real time, you might see a breast radiologist note that something is spiculated, and that is going to be something that is more likely to be cancer because we're worried about it. And indistinct is also something that is often worrisome. And on the other end of the spectrum, something that is nice and circumscribed might be a benign cyst, and that is less likely to be malignant. And so we use these terms. Obscured means that it probably is circumscribed, but there's tissue that is overlapping and in the way, and so we can't comment on all the margins. On microcalcifications, we look for malignant microcalcifications or cancerous microcalcifications almost always occur in the ducts. And these occur in a dot dash branching pattern, and they tend to be irregular calcifications that vary in size and shape. There are also benign calcifications in the breast. So women can develop calcifications that are not cancerous, and we will see them on a mammogram, and sometimes it's difficult to differentiate between something that is a cancerous calcification and something that is benign, but they tend to be smooth. These are rod-like calcifications that occur in the duct. So these tend to be benign. So we need to try to differentiate between those two. And we also, like I said before, we look for architectural distortion, and that is the change in the surrounding tissue that the cancer makes. So the cancer will pull in normal tissue, and we sometimes just see that focal change in the parenchyma around a cancer. And the last thing that breast radiologists will comment on is the density of a woman's breast. So these are the 4 classifications we use. On a mammogram, fat will be dark, and fibroglandular tissue will be white on a mammogram. And a cancer looks like a white mass on a mammogram. So as you can guess, if you have a white mass on extremely dense breast, you might not be able to see the cancer as well. And so what we do is when we put the report out, and we notify the patients if they are in these the dense categories, because it means that the mammogram might be missing a cancer for them. Okay, breast radiologists use a standard reporting system. This is called BI-RADS, Breast Imaging Reporting and Data System. So we give a number to each report, and this helps us track follow-up. So it basically will tell us if something is incomplete, we give it a category 0. So if we do a screening mammogram and we see an abnormality and we need to do additional views, we dictate a report, and then we also give it a category 0 which means that the patient should come back and we need to do additional mammographic or ultrasound views. 1 and 2 are negative, so everything looks good. The patient should come back in 1 year and just get another mammogram, a screening mammogram. And then there's these other category 3, 4, 5, and 6 where something needs to be done. Category 3 is we see something and we think it's probably benign, and we just ask that the patient come back in 6 months instead of a year, so we can just keep an eye on this area, and we do a short-term follow-up. 4 and 5 are things that are suspicious, and we are going to recommend a biopsy. And 6 is when a woman already has a known malignancy in her breast. Okay, so let's look at a case. This is a 40-year-old woman who has a screening mammogram. Okay, so this is the right CC and the left CC. And the right MLO and the left MLO. So do you guys, oh, MLO, I'm sorry. So MLO means medial lateral oblique, and CC is cranial caudal. So those are the views that we get. So this is from top to bottom. The woman is in compression this way, and we obtain the mammogram. And this is medial lateral oblique. So from the medial and lateral, we've taken an image of the breast. You get 2 views of each breast. I'm sorry, I'm answering a question in the chat. Does that answer your question, Safa? So can you guys tell me where the abnormality is? Do you guys think it's 1, 2, or 3? Yep, 1. Very good. Yeah, I see a lot of 1s on here. Exactly. There's some calcifications in the left breast. And so what's the next step? Now, if that's a screening exam, we call it a BI-RAD 0, and we say the patient needs to come back and we need to do specialized views, okay? And so the patient will get a letter saying, you know, you need to come back and we need to do a diagnostic mammogram, we need to do additional views. And the ordering physician, the physician that decided that that patient needs a mammogram, their primary care physician will also be given a letter so that they know what is going on with their patient as well. And then she'll come back in for a diagnostic mammogram. And for a diagnostic mammogram, that is an appointment with a radiologist, a breast radiologist. And so what happens is we can get specialized views, and we basically can order whatever views we think are necessary in order to come to a diagnosis or a conclusion or a treatment plan. And so in this case, we wanted to get a closer look at those calcifications. And so we got what are called magnified views. So we can take a closer look at the calcifications. And so these are, this is a medial lateral magnification view and a CC magnification view. You still want those two views. And here you can see, I think I was talking about calcifications earlier, that they are irregular calcifications in a branching pattern. And these are really very suspicious for breast cancer, suspicious for ductal carcinoma in situ, which is an invasive ductal carcinoma. Invasive ductal carcinoma is the most common cancer in breast cancer in women. And this is pretty classic of those findings. And we gave it a BI-RADS 5, which is very highly suspicious, over 95% chance that this is malignancy, and recommended a biopsy. She had a biopsy and it came back as invasive ductal carcinoma, okay? So that brings me to a diagnostic mammogram. So like I said, a diagnostic mammogram is performed under supervision of a radiologist. So it'll be a longer exam. What happens is the technologist will come to the breast radiologist and they will explain the situation. They might say, oh, this patient has a palpable lump, and they'll start taking some images and show us the case. And the patient is still at the breast center. And we will go back and forth. We might say, well, she needs an ultrasound now, or we need to do a magnified view of a certain area. And then at the end, after we've gotten all of the information that we need with a mammogram and ultrasound, we will make a decision. And if the patient needs a biopsy, we will go and talk to the patient and let them know that we're recommending a biopsy. So there is some patient interaction for breast imaging. So this is done on a patient if an abnormality is detected on a screening mammogram, and it's also done instead of a screening mammogram in a symptomatic patient. So again, if a patient has nipple discharge, pain, or palpable lump, they have a problem that we need to figure out what's causing it. And so instead of doing a screening mammogram, we just start with a diagnostic mammogram. Okay, case number 2. It's a 37-year-old female with 2 palpable lumps in her right breast. This is a diagnostic mammogram because we don't routinely screen women who are under 40. So she's 37, so it's a diagnostic mammogram because if you are in your 30s or 20s and you palpate a mass in your breast, or you have any type of symptom in your breast, we're going to do a diagnostic mammogram because we don't screen regularly women under 40. And she also had symptoms. So she came in and we ordered a diagnostic mammogram. These triangular markers are metallic markers, and they're stickers that we place on a patient's breast in their area of palpable concern. So if a woman says, right here, I feel something right here, we'll take a sticker and place it right there so that we can correlate between the patient's findings and the imaging findings. So here's the right CC, and you see 2 triangles. Do you guys see a mass right beneath the 2 triangles? Right here? Yes, Safa can see it, right? There's 2, exactly, yeah. Exactly where she's feeling it too, right? You can see sort of there's a mass here and there's a mass here. And here's the medial lateral oblique view. And I think you can also, I definitely think you can appreciate the larger one here and maybe even the smaller one. Okay, so what could we do next? I think I gave it away. We can do a breast ultrasound. So here is one of the masses. This is the breast ultrasound. And we can see that the masses that she's feeling have nice circumscribed borders. So just like mammography, we can use some terms that make us sort of indicate whether we are more suspicious of a mass or whether we think something is less suspicious. And so here, this is a mass that has nice circumscribed margins. It's homogeneous in echo texture. So for ultrasound, we talk about echoes. And if something is hard and cancerous, sometimes that ultrasound beam cannot penetrate the mass, and you're going to have some shadows here because you can't really see the tissue past the mass, and so it just blocks it. And in this case, you can still see the tissue beneath it. So it is a circumscribed hypoechoic mass. And there, if we put Doppler, which tells us if it's a solid mass or not, so that tells you about the vascular flow, you'd have some internal vascularity here. And so this is actually, and here's the second lump too. This is something that looks like the most common benign breast tumor or benign breast mass in women is called a fibroadenoma. And this looks pretty characteristic of it. And we could do a short-term follow-up and just to make sure that that's what it is. And we'd probably give this a BI-RADS 3. Okay. Does anybody have any questions about that? Okay, so what is breast ultrasound? Breast ultrasound is used to further characterize masses seen on a mammogram, and so we can tell whether something is cystic or solid. And as I just told you before, you can use Doppler to see if there's internal vascularity, if there's vessels inside a mass, or whether it's just fluid-filled cyst. And we can also try to determine if a solid mass is benign or malignant. We look at the margins, we look at like I said, whether there's shadowing beneath it or whether the ultrasound beam can penetrate that mass. And so we can try to determine if something is malignant or solid, and that can help us determine whether we need to biopsy it or follow it. We can do breast ultrasound in women who are who palpate a mass. So if they're under 30, we normally just do an ultrasound and we don't do a mammogram at the same time. But if they're over 30, we do a mammogram and an ultrasound. And that's because we don't want to radiate women when they're young, especially if the likelihood of breast cancer is lower because they're young. And also young women sometimes fall into that dense breast category that I showed you before. And so we might not see anything on the mammogram anyways. So breast ultrasound is used to characterize masses, and it's also used to guide for biopsies because breast radiologists perform biopsies and procedures. Do you guys have any questions about ultrasound? Okay. So image-guided intervention, one thing that I love about breast imaging is that we not only get to interpret cases and talk to patients, but we also get to perform procedures. And so there are a couple different procedures we do. We can do ultrasound-guided biopsies, and I'll talk about some of the other ones too, but basically an image-guided intervention is when we identify the abnormality or the lesion with some type of imaging modality, and we watch the needle and we do a biopsy. So this is a percutaneous, minimally invasive procedure. So the patient is awake. We numb up the patient's skin and deeper into the tissue so that they're comfortable, but it avoids an open surgical biopsy for benign lesions and also lets the surgeon know exactly how much disease there is and where the disease is if it is a malignant lesion. So they only really have to take the patient in to the OR once. And that is good because, as you know, the risk of surgery, sometimes the risk can be higher for certain patients, especially if they have a risk for anesthesia. Okay, so like I said, we can do an ultrasound-guided solid nodule biopsy. And we can also do a ultrasound-guided cyst aspiration. Now, a cyst is something that is benign. It's fluid-filled. It's never going to become a cancer. But sometimes cysts can get very large, and we need to drain it for symptomatic relief so that the patient feels better. So we don't need to, but if the patient says, oh, this is very painful, can you drain it for me? We can do that in breast imaging just for some symptom relief. Breast radiologists also do what's called mammographic guided biopsy. So this is called a stereotactic biopsy. So sometimes you see things only on a mammogram that are worrisome, and therefore you need to be able to use the mammogram as a guide and do a biopsy using the mammogram, and this is called a stereotactic biopsy. So calcifications are something that we really only see on mammography. You can see them on ultrasound, but just not as good as you can see them on mammography, and you really can't see them that well on MRI either, but sometimes that's a sign of cancer. Sometimes that's the only sign of cancer, abnormal calcifications that are increasing in number. And so we need to be able to do a biopsy. And the last type of biopsy that we do as breast radiologists is an MRI guided biopsy. And I'll show you how we do that in just a minute. So let me show you another case. This is a 42-year-old female with a new right breast mass. And I think you guys can all see this mass right here with this palpable marker on the CC view. And here's an MLO view. Again, a large right breast mass that was bothering her. If we did an ultrasound, what do you guys think this looks like? It's a cyst. Yeah, so this is a circumscribed mass. It's anechoic, so there's no echoes. The ultrasound beam can easily penetrate through this simple fluid, and this is what's called posterior acoustic enhancement, because the ultrasound beam can easily penetrate through that. And if we put Doppler, we would not get any internal vascularity because this is fluid. There's no vessels. So Safa asked a question in the chat, and she said, for cyst drainage, isn't it still possible for it to fill with fluid again? That is a great question. Yes, absolutely. It is not a cure. When we're draining it, we're just collapsing it, and the capsule, it absolutely can fill again. And part of our consent when we do the procedure and tell the patient, before we do the biopsy or before we do the cyst drainage, is that this could recur, and this is just for symptomatic relief. And there are women who have multiple cysts and it's not painful for them at all. So really it just is very dependent on women, and most of the times we don't end up doing cyst aspirations unless, like I said, they're very large, and sometimes if they're right by a patient's underwire or bra, it might be uncomfortable, and sometimes they ask for it to be aspirated, but it certainly can recur over time. And is there a way to permanently remove it? If you do, it would be a little bit overkill to do surgery to remove an entire cyst. I have not seen that occur. I think that because there's no malignant potential, women just do percutaneous drainage if it really bothers them, and women don't end up going to surgery to remove that tissue. Partially also because some women who have these large cysts, they might have them everywhere in their breast, and so it's not going to really help to play whack-a-mole and take one out and then you get it in another area. So that's not really what people use for treatment for cysts. Do we have any other questions? These are great questions. Okay, so this is one way we do ultrasound guided biopsies. The patient is on her back and she puts her arm behind her head so that the tissue is opened up. We identify the abnormality with ultrasound. And under ultrasound guidance, we clean the tissue off. It is a clean procedure. We put a cover over the probe. So this is something that, there's a cover, a bag that goes over the probe so that in case there's some blood on it, again, it's a clean procedure, and we wear gloves. We watch as we administer lidocaine. So Everywhere that your needle is probably going to be to take a tissue sample, you want to make sure that that tissue is nice and numb, so we numb up the skin and numb up deeper. And then if it's a cyst aspiration, we would just use a syringe and a spinal needle and just aspirate the fluid out. If it comes back as fluid that looks typical of a cyst, meaning sometimes it's like a greenish gray fluid or a straw colored fluid, we just throw it away. We don't even send it to the lab for sampling because everything is so characteristic of a benign cyst. Now, if there is some concern, if there is a solid component to it, we would take a tissue sample of that solid component. If it came back as bloody or of concern like that, or certainly if it looked like it was infected, we might send it to the lab, microbiology for analysis or cytology for analysis if it was bloody. So that's what we would do for a cyst aspiration. If it was a solid nodule biopsy, we watch as our needle goes right into that mass and it takes a tissue sample. And we tend to take about 3 to 5 samples of this mass, and then we send it to the pathologist for analysis. And these are some of the tools that we might use. This is a larger needle that has vacuum assisted guidance. So what we do is we place that needle right underneath the mass, and it actually sucks the tissue in, it cuts a small portion, and then it pulls it back to a basket in the back. And then we just do that a couple of times until we have enough tissue. This is what's called a core needle biopsy, and this is a smaller needle. It works well for hard lesions where you just need to shoot in and take a small sample, and that just is able to take small tissue samples. It's also less trauma to the breast, so sometimes we use it for something that also could be a large mass that might be like a fibroadenoma that might be benign in a female, but just to confirm. I have a question in the chat. Is there any medication that can be taken to prevent the cyst from recurring, or to relieve symptoms? That's a really good question. No, there's no medication. Cysts sometimes can be associated with a woman's menstrual cycle as well, and hormones. And so sometimes perimenopausal women will get in sort of increased activity of cysts. And where do they come from? These are great questions. So there's really no medication that people recommend. You might read somewhere that caffeine increases cysts, but there's really no good clinical study that says that decreasing caffeine will decrease cysts. So I do not recommend to patients that they go off of coffee when it's not clinically proven, or any caffeine. And there's no medication that we really recommend. We don't know why some patients get, it says why do cysts form? Again, I think there's some hormonal influence, but why some patients develop cysts and fibroadenomas versus other patients that have, no masses in their breast, that's a genetic, that's probably from genes. Alexandria says, is it possible to perform aspiration biopsies on a patient with breast implants? Is it more difficult to perform? Very good question. It is definitely possible to perform, as long as, it's definitely possible to perform an ultrasound guided procedure. Sometimes that mammographic guided procedure is difficult because we might not have enough tissue. So it is more difficult sometimes. You definitely want to make sure that you don't rupture a patient's implant. I haven't ruptured an implant yet, but we do, when we do the informed consent, we do tell patients that, we're going to watch our needle going in, and we're going to keep it as far away from the implant as possible, but we have to get the tissue sample. But sometimes there's a cancer or a lesion that's sitting right on the implant, and you're very close. That's another reason why we like to do it under ultrasound guidance, is because it's what we call real time. So you've got your probe there, and you're watching your needle go in, and you're watching the tip of the needle and making sure that it's very far away from the implant, and that it's right into the mass. So yes, it's possible to perform, and I do think it's more difficult. Speaking of implants, we can do mammograms on patients with implants as well, but we have to get 4 more views. So we do the standard CC and MLO views of each breast, but we also do the breast with the implant in place view, so everything. But we also do views, each of those views again with an implant displaced view. So the implant is pushed back and the technologist just compresses the tissue anterior to the implant. And this is important because the compression is what keeps the tissue still. And so if we have a lot of motion on a mammogram, we might not be able to see something because it'll be blurry, just like a picture when you have motion. And also it compresses, so it sort of takes it thins out the breast and sort of removes some of the overlying tissue. So we want to try to do that if possible. Okay, so Ashley says, can having breast implants correlate to having masses in the breast due to infection, improper insertion of the implant, or other reasons? So breast implants, you aren't at increased risk of infection down the line. Obviously, right after surgery, you've put something, you've caused an incision in your skin and you've put something in, so you can have a post-operative infection that obviously somebody who didn't have implants wouldn't be at risk for. But one thing that is potentially, I don't know whether it's in the medical news for the last few years, and more so in the last year, is what's called it is a lymphoma that can be associated with breast implants. It's pretty rare, but what's happening is that your body is, you can develop a B-cell lymphoma from having the implants, and and so you'll have maybe like a thick capsule or fluid around that implant. And that's how we suspected on a mammogram that there could be a B-cell lymphoma that's developing because of that implant. So a cancer that's actually happening because of that implant. And the treatment for it is just removal of that implant. So you don't have to have chemotherapy, but you just have to remove that implant, and that's how you treat it. And they're finding that it could be associated with, there's different types of implants. There's like a smooth implant and there's textured implants. It could be associated with textured implants. So I know that's a little bit of a tangent, but Ashley, you were asking like maybe what things can happen if you have implants. They don't really correlate with, you know, other masses besides this lymphoma. Does that answer your question? Okay. Yeah, these are great questions. So a stereotactic biopsy is a mammographic guided biopsy. Like I said, sometimes you see calcifications only on a mammogram. And the way we do this is, it seems a little bit funny, but this is what works for us, is there's a table with a hole in it. And the woman lays on her stomach and her breast goes through that hole, and then we take a mammogram. And what we do is, there's a couple different ways to do it, but the traditional way is you get 2 mammographic views, and they're called stereotactic pairs. So when you use your mammogram to target a lesion, you need 3 coordinates, right? You need the X, Y, and then the Z, the depth coordinate. And on a 2D structure, you can always tell the X and the Y coordinates, right? It's sort of like Battleship. You know exactly where something is, but you don't know the depth of the lesion. And the way we determine depth of a lesion is we do a mammogram at 15-degree angle, positive and minus, and we see how did the lesion move. And based on the distance, how much it moved, you can basically do geometry and figure out the Z, the depth of the lesion. Does that make sense? So that basically tells us, after we do 2 views, we tell the computer exactly where this is the lesion here, this is the lesion here, and it can calculate the depth, and it tells us the X, Y, and Z coordinates. We place the needle at that X, Y, and Z coordinate. We take another mammogram to confirm that our needle is in the right place, and then we take tissue samples. And then what we do is we X-ray the tissue samples. And I don't know whether you can see, you probably can't see it very well, but when you X-ray the tissue samples, you're looking for the calcifications. And this also confirms that we got the right spot. So I told you about ultrasound guided biopsies and how we feel confident that we really sampled the right spot by watching our needle go in. For stereotactic biopsies, you don't really actually watch real time your needle go in because you're not taking a mammogram exactly when it's taking samples. You take a mammogram before you place the needle and then after you place the needle. But while you're taking tissue samples, you're not taking an image. So the way we confirm that we're in the right spot and that we really got the area is we X-ray the tissue sample. Does that make sense? Okay. And the last type of biopsy the breast radiologists do is what's called an MRI guided biopsy. So we also interpret breast MRI. And the way that a breast MR is done is the patient is on their stomach, and we take images of their breast. For a breast MR, they aren't in compression, but when we do a biopsy, we need to make sure that their tissue isn't moving as we place a needle in. So they are in compression as we do an MR biopsy, and we place this grid over their breast. So we put them in compression, and there is a grid that's placed over their breast. We give them contrast because that's how a breast MRI works, is you give contrast or gadolinium into a vein and you look for areas of enhancement. So a breast cancer will show increased vascularity as it recruits blood vessels. As it grows, it's growing abnormally. And so it's got a lot of vascularity, a lot of blood flow. And so that's what we're looking for on breast MRI. And so if we, when we're doing a biopsy, we identify the area, the abnormal area, and the computer will tells us exactly where the X, Y, and the Z depth is. So it'll say you need to go in B3 grid, and it has these smaller holes in there too. You put this little insert in, and it can tell you exactly where in that grid hole that you placed your needle in. And then it also tells you the depth. So there's these little markings for depth on the needle guide. And then you just place it into the right area. You obviously make a little nick in the skin, and the needle is sharp, and we just sort of put it in. And then you do another image on MRI to confirm that you're in the right spot. And then you take, and then you pull the patient back out. Sorry, this is how you take the samples, pull the patient back out, and then you put this vacuum-assisted device in, and you take tissue samples. Now, unfortunately for MR guided biopsy, none of it is real time. We don't have an X-ray to sample, to look for calcifications, and we don't, like ultrasound, watch our needle go in. So because it's not real time, we have a map, and then we pull the patient out, and if they move, our map is changed and we don't really know it. Because of that, we take a few more tissue samples and we use this vacuum assisted biopsy. So that's why we try to reserve MR guided biopsies for lesions that are only seen on MRI, that we can't find a correlate on mammogram or ultrasound, because this is a more expensive exam, a more expensive test. It's harder for the patient because it's longer, and like I said, it's not real-time sampling, and so we have to take additional tissue samples, and sometimes they can get a little bit more bleeding. Okay, Safa said, there's no weird questions, there's no bad questions, so please keep them coming. I love these questions. But it says, is an MR biopsy less effective for women that have very little fat in their breasts? So you mean if they have dense breasts, is it hard to place the needle in? Is it less effective? Or are you talking about, is MRI, smaller breasts? Yes, it's not less effective. Sometimes it can be difficult because you need to have enough tissue to pull it into the grids, right? We normally don't have problems with, we can have problems with the thickness of the breast. So for stereotactic biopsy, or that mammographic guidance, and for MR biopsy, you need to make sure that the breast isn't too thin. So, patients that are maybe smaller breasted, when you compress the breast, it might press to be something that is under 2 centimeters or under, like 1.5 centimeters. And the problem is that when you do a biopsy, you have a needle and it's got a trough, right? And it needs to be able to fit within that breast tissue. So if it's sticking out on both sides of the breast, it's, as you use the vacuum assisted biopsy, it's going to suck in the patient's skin, and you can't do a biopsy if the needle doesn't fit in the breast because the breast is too thin. Does that make sense? So there are some issues. And if the breast is too thin, there's things that we can do to try to get a smaller needle in. We have petite needles, but those, you know, they don't obviously have as good of a sample because they're smaller. But there are occasions where we just have to send them to surgery, and they have to do a tissue sample that way. It doesn't happen very often, but it can. So I hope I answered your question, Safa. And if I didn't, please please let me know in the chat. Okay, good. Thanks. She said yes. Okay, another case. This is a 45-year-old female, and this is a screening mammogram. Okay, right CC and left CC. You guys are pros now, so I'm going to ask you guys, do you guys see anything? There's a mass on the right CC. Yes, very good. There's a mass on the right CC. It's a spiculated mass right here. Here is the right MLO. And there is also a little mass right here too, right? It's right there. Okay, so those are the findings. So this is a screening mammogram. So what happens to this patient? Do you guys remember on a screen? Perfect, Alexandria. Diagnostic mammogram is next. So we call it a BI-RADS 0, which is additional images are necessary. The patient gets a letter and a phone call saying, hey, we need you to come back. We need to do some more views to try to figure out what is going on. And her ordering physician is also notified. And then she gets another exam, which is called the diagnostic mammogram. And on this diagnostic mammogram, we did what's called a spot compression view. So sometimes if we see a mass or what we call an asymmetry, we put some extra pressure or spot compression on a certain area. And the idea is that if it's a cancer, it's not going to smooth out. If it's just overlying tissue, it's going to sort of smooth out. And so it's going to just look like tissue. But if it's a cancer, it's hard, right? So as you press on it, it's going to stay hard and true to form, and then the rest of the tissue is going to just sort of smooth out. So here, what we say is that spiculated mass persisted, and it continues to look spiculated with these irregular spicules with a little bit of distortion around it, and then you also see the small mass here, right? So, that is the spot compression view, and what next we would do. And ultrasound, I keep on getting ahead of myself. What do you guys think about this? Does it look like that cyst that I showed you? Yep, there's shadowing, exactly. Safa's right, there's some shadowing. This is not smooth like the cyst, okay? There's some, like it's a little bit of lobulated mass. And so this does not look like the cyst. This is something, here is the other mass. Remember I said there was a smaller mass too? So what we did is we went and we looked for both of those in the right breast. And here, this one has sort of angular margins. It's shadowing. There's another terminology we use for something that is suspicion, and what we say is it's not parallel to the chest wall. So here's the chest wall, and here is the skin, okay? So a mass that is benign will respect tissue planes, and it'll probably grow this way along the tissue planes. But if it's a cancer, it doesn't care, and it's not gonna respect those tissue planes, and it's gonna maybe dig deeper into the breast. And so what we say is it's either taller than wide, or it's not parallel to the chest wall. So this is another indicator how it's sort of tall right there, that is something that is suspicious. So both of these are suspicious, and these are I can't see the distance here. They're 2.8 centimeters away from each other. And that is important to know as well. So what would you do now with these two suspicious masses that we saw on mammography and ultrasound? What would you recommend? We would do a biopsy, right? Because we need to get a tissue sample. We're pretty suspicious of both of these masses, and we need to do a tissue sample. So Safa said, our malignant tumors never parallel with the tissue. So all of these characteristics that we talk about, the margins not parallel to the chest wall, we talked about the echogenicity and shadowing. These are, there's just a number of indicators, but you know, you don't need all of them to be suspicious or to have or for something to be malignant. And so what we tend to do is really, if there's just one malignant feature, that we are going to probably do a biopsy on it. The more we have that we add up, then the higher suspicion we go, and sometimes we get into that BI-RADS category 5 where we're sure that it's cancer. So, you know, it's shadowing, internal vascularity, spiculated margins, maybe there's some associated microcalcifications with it, you know, like I said, taller than wide, not malignant to those types of things. If you check all of those boxes, then you're going to maybe be heading into that BI-RADS category 5 where we're very, very suspicious. Okay. So we're going to do an ultrasound guided biopsy for both of these. Now we saw them on the mammogram, so technically you could do a mammographic guided biopsy, but the easiest for the patient and the quickest for us to do is an ultrasound guided biopsy. And again, we can watch the needle go in, and so that's why we would probably do an ultrasound guided biopsy for this, and patients prefer it because they're not in compression. So that's what we would do next. We would recommend an ultrasound guided biopsy. So here is an example of one of the lesions being sampled, and so you can see this is the needle and this is some of the mass, and you can see that they're right in there and they're just taking a tissue sample of that. Okay. And then what happens is, in a couple of days, we hold the report. So we dictate a report, but we don't finalize it. Okay, and we send the tissue sample to the pathology lab, and in about 3 to 5 business days, about 3 days, we get the tissue, we get the pathology results, and we look at those results. Breast radiologists look at those results, and we think, does this make sense? Well, this is called radiology pathology concordance. So sometimes if you do a biopsy and you're really suspicious on imaging, but your pathology results come back as benign, you have to question, did you miss the lesion? Did you undersample the lesion? And you might need to recommend for this lesion to be rebiopsied. And so breast radiologists take all of that information and we finalize our report. And so in this case, it would be the findings came back as invasive ductal carcinoma and DCIS. Like I said, the most common breast cancers, both of them did. And what we would say is, I would say, okay, these are malignant findings, they're cancerous findings, and it matches the imaging findings, it's concordant. If it was benign, if the pathology results came back as benign, I would dictate it. This is the pathology results were benign, but this is discordant. This doesn't match. The radiology and the pathology reports do not match up. There's a disconnect. And so, and then we would make a recommendation so that, you know, the patient and the ordering physician knew that we needed to go back and maybe resample, or maybe they needed to go to surgery and just take a large area out. So this came back as something that was malignant, and the patient then went to see a breast surgeon and decided, you know, their treatment options. You know, because this was a smaller area, they opted for a lumpectomy. So patients can get a mastectomy where they get their entire breast taken off, or they can get a lumpectomy where a section of the cancerous tissue and the breast is taken off, and they can get radiation just to that site to sort of sterilize it of any malignant cells. Oh, I'm sorry. I had a question in this. Safa said, how common is breast cancer in women? 1 in 8 women, unfortunately, will be diagnosed with breast cancer in their life. And how can one decrease their risk of getting it from early on in their life? Okay, so just like everything else, a healthy lifestyle can help. Eating well, exercising, so that if you are obese, you might have more estrogen, and so that can affect your risk of breast cancer. So a healthy lifestyle, drinking in moderation, smoking, all of those healthy lifestyle things can decrease your risk of breast cancer. Genetics plays a role in breast cancer, but most patients who are diagnosed with breast cancer do not have any family history. So that's not, I know that there's some patients that are surprised that they have breast cancer, and they say, well, I don't have a family history, so how do I have this? Unfortunately, most women who get it, don't have a family history. And your question of how can one decrease the risk of getting it early on in life? Now, unfortunately, patients who get breast cancer early, so like in their 30s, and even in their 40s, those do tend to be ones that are associated with genetic abnormalities. Younger patients do. So that's not really something at this point that we can prevent. But early detection is key. Patients who are diagnosed with breast cancer in stage 0, which is DCIS, or 1, stage 0, which, like I said, is that is ductal carcinoma in situ before it's become invasive, has a 99% chance of survival. So it's really, that's the reason why we screen. It's because early detection really helps save women's lives, and it also gives them more treatment options that are less invasive. Okay, so for this patient, we found out that she had breast cancer, and she decided with her surgeon that she was going to get a lumpectomy. So surgeons cannot take a patient to the operating room, and if they can't feel the cancer, they won't know exactly where to do surgery, right? So this is another area where breast radiologists step in, and we help guide the surgeons to the site so they can localize the area for surgery. And we do that in a couple of different ways. This is one way that we can do. This is called a wire localization. So some surgeons want a wire. So you basically place a wire into a patient's breast where the cancer is, and then the surgeon can follow that wire from the skin down. They cut along the wire, and then where the wire is hooked and the thick portion of the wire is where the cancer will be. So we basically take, put the patient in compression. We use an alphanumeric grid, and that tells us where the lesion is. So in this case, I would know the lesion is in D7. So then I walk over to the patient, and I see D7 on the grid, and I place a needle with a wire in that spot, in both spots. And then we take the other view, and we pull the wire back to make sure it's the thick portion of the wire is right where the cancer is. And then the surgeon, then she goes to the OR, and the surgeon can basically follow this wire down and then identify the cancer. Okay, does that make sense? Okay. And so that's what they do. And then after that, the surgeon will take out the tissue. So we also look at the lumpectomy specimen to make sure, right when the patient is in the OR, the surgeon will take out the piece of tissue, take an X-ray, and we'll look at it as breast radiologists, and we can say there are 2 wires in the specimen, there's 2 masses with the clips from the biopsy, and you have everything, and it's in the center. And so we don't think that the margins, like the tumor is not right up against the edge, and so there's probably no cancer left in the breast. And so we have that conversation with the surgeon that everything looks good, and then they can close up the patient. Okay. And that is, and then you get you get the pathology result from that specimen too. And in this case, it said invasive ductal carcinoma grade 2 foci, measuring 2.1 centimeters and 6 millimeters, which is really just like what we saw on the mammogram and ultrasound. Invasive carcinoma is present, and it was intermediate nuclear grade, okay? And they tell you how close things are to the margin, okay? So the patient returned in a year, and this is what her mammogram looks like. She completed her lumpectomy and she completed her radiation, and she returned to her annual screening mammogram. So she will just every year get a screening mammogram, and here is her right CC. Now you can see these are surgical clips, and we put the sticker, which basically says this is where her scar marker is, so we know exactly where she had surgery. And here is the MLO view. And there's no cancer left. Do you guys have any questions? You guys had great questions today. Oh, good. I'm glad. If you have any further questions, I can put my email in the chat. That's my work email. And thank you for your attention. I think we are almost on time, and that is it.
Yeah, if no one has any questions, then I think that's it. Thank you so much, Doctor, for coming here today.
So Michelle, she says there is a question in the chat. Oh wait, never mind. Okay, all right. All right. Okay, great. Thank you so much.
Thank you. Bye.